I am presenting data on Idarubicin, Cytarabine plus Nivolumab, pilot phase 2 trial that we conducted at our institution. And the hypothesis behind this is that immune dysfunction plays a role in management of patients with acute myeloid leukemia, and if we can actually resume immune function, we can actually try to improve the outcomes, reduce the number of relapses, and overall improve cure rate in acute myeloid leukemia. The study was conducted in a relatively small cohort of about 35 patients with newly diagnosed acute myeloid leukemia who were younger than 60 years in general, although we did allow a few patients between the ages of 60 and 65 who were deemed to be very fit and able to tolerate intensive chemotherapy. The regimen was with Idarubicin and Cytarabine, and Nivolumab, which is a checkpoint inhibitor, was started about day 24 after initiation of induction and was continued every 2 weeks for up to about a year. In general, the regimen was as well tolerated as any induction chemotherapy regimen, with the most side effects being related to the myelosuppression that you would expect with the combination of Idarubicin and Cytarabine. There were a few events that were thought to be related to immune-mediated side effects, but they all essentially responded to appropriate managements with the initiation of steroids. And the response rate overall was 76%, including 61% complete response and 15% CRI. In a short follow-up, a relatively short follow-up, and comparing the data with a contemporary population of patients treated with Idarubicin and Cytarabine, essentially the same chemotherapy regimen, there has not been a statistical significant superiority for the addition of Nivolumab, although the CR duration appears to have a trend for improvement. Obviously, this is a small population, and nobody should make significant conclusions about this. However, it does show that this regimen is possible, and addition of checkpoint inhibitors to induction AML chemotherapy is feasible with no dramatic increase in toxicity. I also want to mention that 9 of the patients proceeded to an allogeneic hematopoietic stem cell transplant, and there was no marked increase in incidence of severe graft-versus-host disease. There was 1 patient with grade 3 or 4 graft-versus-host disease who responded to appropriate therapy. So overall, I think the take-home message for the practicing oncologist is that addition of checkpoint inhibitors such as Nivolumab to induction AML chemotherapy is possible. Before this should be used routinely, there should be larger randomized trials to demonstrate that this strategy is truly beneficial or not.